everyone. I hope you're having a great Wednesday. My name is Olivia. I'm a third-year med student at the University of Iowa Carver College of Medicine. I've done a couple of these before. I did one on pneumonia back in, I think, June, maybe May. And then I did another one on melanoma about a month ago. So you might have seen me before on these. I really love doing these. Today we're going to talk about a surgery topic, which I'm super excited about because I'm pretty interested in going into surgery. So if any of you guys are interested in surgery as well, I'd love to chat with you. Today we're going to be talking about small bowel obstructions. It is a very common surgical problem. You'll see them if you go into emergency medicine. You'll see them if you go into surgery. You'll see them if you, your patients will probably have them if you go into some sort of primary care. So definitely something to be aware of. And Stephanie will have had a little experience with this, so that's awesome. We're gonna just go ahead and get started. So this is one of my favorite artists. This isn't like a promo or like ad or anything. It's just a cool artist that this picture is a cross-section of the abdomen, so you can see kind of the organs here. So for today, we are going to go through a case and talk about physical exam findings, a differential diagnosis for abdominal pain, and then wrap up with assessment and plan and focus a lot on the pathology of disease. And Kendra, okay, perfect, thank you. Yeah, I don't know why the link isn't showing up anymore for people, but if there's continued problems with that, then I really appreciate if somebody could just copy and paste that in the chat. It really is helpful. So as you all probably know, if you're familiar with this, to have the SOAP note out to fill in throughout the presentation. And then at the end, that there's a 10-question quiz, and you can have multiple attempts at that. And it's for a certificate of completion, I believe. And also just kind of fun to check your understanding. So here's what the SOAP note looks like. Hopefully you have that up. There's a couple. A 72-year-old female presenting to the emergency room with a chief complaint of abdominal pain. So just off the bat, no wrong answers here. What are some things that could cause abdominal pain? You can put them in the chat or you can unmute yourself, whatever is easier. Appendix, great. Gallbladder, perfect. MI, yeah. Gas pain, SBO, Food poisoning, yep. These are all awesome. I like to think of them as kind of different types of etiologies. So we could have something like an infectious process, so like viral bacterial type thing. We could have a maybe metastatic process, which would be like cancer. We could have inflammatory process like pancreatitis. Those are all kind of like really great examples of what could cause abdominal pain. So good work, guys. We just kind of went through some of this. I've broken these down, and this is not an exhaustive list. I could probably make like an entire slideshow out of just differential for abdominal pain, but some key ones, which I think a lot of people got most of these. The ones that are in bold over here are like surgical abdominal pain diagnoses. So we have appendicitis, mesenteric ischemia, which is kind of, it's like a blood clot in the arteries that supply your bowel. Peptic ulcer, perforation especially, and then bowel obstruction are just a couple of examples of what could be a surgical treatment for abdominal pain. We also have some inflammatory processes, irritable bowel disorder, which is a functional abdominal problem. And then cholecystitis. Does anybody know in like simple person terms what cholecystitis is? Gallstones, yeah. So it's inflammation of the gallbladder, usually secondary to gallstones. Excellent work. Pancreatitis, someone mentioned that. Colon cancer. And then we have a couple of other processes. I think somebody said MI, which is great. You always want to think of what could also be outside of the abdomen causing these things. So we have a couple pelvic type etiologies: ectopic pregnancy, ovarian torsion, especially our patient's female. You can have other, gender specific or sex specific diagnoses in the pelvis that could cause abdominal pain. Somebody said kidney stones, I think. That's a great one. Panic attack and anxiety. These are just a couple of examples, again, but just to try to think broadly. So I think there's a couple questions here. For the recordings, I'm not sure exactly when Becca would know that, and I can ask her, but it's usually a couple of days after this is over. So probably by the end of the week. And then for an MI, which if people don't know, that's a myocardial infarction or a heart attack in sort of layperson terms. Yeah, this can be referred pain, and there's a little bit of difference between how you see what men and women present if they have an MI. So it's more likely for women to have atypical presentations, which doesn't make a lot of sense because they're half the population. So I feel like we should just include all the different presentations and what could be a possibility. But yeah, women tend to have a little bit more of like epigastric, which is sort of upper abdomen pain, and men usually have more of the like shoulder, chest type pain, and it varies depending on the person as well. So yeah, referred pain is a mechanism of that. And then I think also depending on which artery is actually occluded could probably influence the pain as well. That's a great question. Kind of getting back to our case though, this is a diagram that I think is really helpful to kind of break it down by location. Up in this epigastric region, like I mentioned before, myocardial infarction is a possible differential, as well as pancreatitis. It's kind of hanging out in the middle of your abdomen. The rest of these are kind of broken down into quadrants. So for right upper quadrant, we think of things like cholecystitis, or which is the inflammation of the gallbladder. Usually gallstones cause that. Pyelonephritis, which is a kidney infection. It's like when a UTI progresses up the urinary tract and enters the kidneys, as well as ureteric colic. I don't know what the actual word is, but that's like if you have a kidney stone. Hepatitis, inflammation of the liver. So organs up here are like hepatobiliary. So you get the liver, the gallbladder, and your kidneys are kind of more in the back as well. And the left upper quadrant, that's kind of where your stomach and your spleen hang out. So a gastric ulcer would maybe present either epigastric in this middle part or in the left side. Again, pyelonephritis, you've got two kidneys, one on each side, so that would make sense. And then your spleen is in sort of the back right corner. I keep saying right, I'm sorry guys. The back left corner of the abdomen here. In the right lower quadrant, very, very classically appendicitis. That's the first thing that I personally think of when someone says right lower quadrant pain. But again, like we saw, don't just close off your differential too early. Think of some other things that could cause that as well. So hernias down here, if you have inflammatory bowel disease, you get some sort of pelvic or gynecologic things like an ovarian torsion or possibly an ectopic pregnancy. And then similarly in males, a testicular torsion. Even though the testicles are technically out of the abdomen or out of the pelvis, they are down sort of externally, they can still have pain in that area. And then in the left lower quadrant, these are just some additional examples. Diverticulitis is some outpouchings from the colon. Don't worry about that, you guys, if that's new to you. It's not super important for this presentation. The main point of this slide is to just kind of show you why you can sort of think of things in different quadrants in terms of narrowing your differential a little bit. So for case details, since we only really got just her chief complaint, we now know that her pain began 2 days ago and is gradually worsening. She now has a 10 out of 10 pain. She's here in the ER and she's in excruciating pain. This pain for her started in the periumbilical area, so around the belly button or in the middle of the abdomen, and is now diffusely tender around her entire abdomen. Her pain is associated with nausea and vomiting over the last couple of hours. So it looks like this pain has progressed to including a couple of other associated symptoms, and nausea and vomiting are two that you definitely don't want to miss. Her last bowel movement was 6 days ago. Now there's a lot of variation in what people can have for what's normal for them. Some people don't go very often. They don't have bowel movements every single day. So to have a baseline and ask them, what is it typically like for you? Some people are super regular and some people aren't. But 6 days is quite a long time to go without having a bowel movement. So that's important information. She's also not passing any gas. So both of those are pretty important in terms of determining your overall bowel function. So this is some good information in like the subjective portion of your SOAP note. And if also I advance to a slide and you guys want to fill this in later, then once we're done with the presentation, I'll go back and you can like fill in whatever. But really the SOAP note's just for like the experience, and that's not part of what you're technically quote graded on. So don't worry too much about it. So in addition to her HPI or her history of present illness, we also want to talk about her past medical and her past surgical history. So she's, I think, what did we say, like a 70-something-year-old female. So a lot of people at that age, they tend to have other comorbidities. This patient in particular has hypertension, she has type 2 diabetes, she has atrial fibrillation, and she has GERD, which is gastroesophageal reflux disease. So she's got some pretty typical things for that age. Good to keep in mind. And we can kind of correlate these to her medicines that she has down here as well. So she's allergic to penicillin. If we're kind of matching these medical conditions with the medications, lisinopril is a very, very common medication used to treat hypertension. It's in the class of meds called ACE inhibitors. That's not something that I learned until I was in med school, so you don't have to worry so much about the mechanism or even that that's what it's for. It's just maybe something that you'll see in the future. Type 2 diabetes, the first line drug for that is metformin. For atrial fibrillation, we like to have our patients be anticoagulated to prevent blood clots and strokes. So warfarin is a blood thinner that she's on. And then for her GERD, she takes omeprazole, which is a proton pump inhibitor. And that basically reduces the amount of acid that the stomach produces, so you don't get that reflux symptom. Those are just some details that I don't want you guys to worry too much about. Just if you're curious, that's kind of the correlation here. Additionally, for her past medical history, she's smoked a half a pack of cigarettes per day for 20 years, but she's quit 30 years ago. So she's kind of beyond the window of what we would be concerned for in terms of smoking risk for like certain cancers and stuff, but definitely still good to know. And she's also never used alcohol. So especially when you're in surgery, but with any like good medical practice, you should take a thorough surgical history as well. It's very relevant to small bowel obstructions for reasons that we'll talk about a little bit later. But this woman has a very extensive surgical history, particularly abdominal surgeries. So she has had a total abdominal hysterectomy, which is the removal of her uterus. And you can do this either laparoscopically, which is minimally invasive, or you can do it through a big open incision. So hers was a big open incision going down the middle of her abdomen to take out the uterus. She's also had an appendectomy and a laparoscopic cholecystectomy. So she's gotten her bladder or her gallbladder, and her appendix both out. So that kind of eliminates those as being potential causes for her abdominal pain. And then she's also had a history of a Roux-en-Y gastric bypass, and that's like a weight loss surgery, a bariatric surgery to reduce the volume of the stomach. So overall takeaways from this slide is that she has had an extensive surgical history to her abdomen in particular. And that's relevant to us because, as I'm going to talk about very soon, something called adhesions, which are things that can happen then after you have this sort of extensive surgical history, are very high risk for having bowel obstructions in the future. So now we're moving on to the objective portion of our note. First, we're noting her vitals. Her blood pressure is 89/61. Her heart rate is 104. Her respiratory rate is 26. Her temperature is 39.3 Celsius, and her oxygen saturation is 94%. So normally I ask people what looks normal and abnormal about vitals, and I'll just spoil this one that none of these vitals are normal. Her blood pressure is low. She is technically hypotensive. Anything under 90 systolic is pretty concerning. And she also has this tachycardia, or this high heart rate. So those together mean that she has this sort of either potential or impending hemodynamic instability. Her body is working really hard to get blood to where it needs to go so they can meet the oxygen demands of her body. So when your blood pressure drops, your heart rate will compensate by beating faster. That's why you get faster heart rate. It's over 100. She's also breathing faster because her body is requiring more oxygen. She has a temperature, meaning she's probably got some sort of infection somewhere, and her oxygen is low because we just talked about that. So all of that is not looking very good. On physical exam, normally we start with just a general appearance. How do they look when you go see them? Does the patient look sick, or are they looking okay, like they're relatively healthy and not any distress? This patient's in moderate distress. They're holding an emesis bag. Emesis is just the medical term for like vomit. So they're holding a barf bag, basically. And she also appears diaphoretic. I always think that certain medical terms are super extra and not necessary to have them be like long and sounding like foreign. Does anybody know what diaphoretic means in like normal person language? Sweating. Perfect, Sarah. Thank you. Yeah, so she's like sweating, kind of like perspiration. So she looks maybe like she like has a fever, is like in some sort of distress. For her cardiac exam, she's got a regular rate and rhythm, no murmurs. Her respiratory exam shows clear and equal breath sounds. And then her abdominal exam is where it gets more interesting. So she's diffusely tender to palpation, which means no matter where you pressed, like in each of the 4 quadrants, she's got a lot of tenderness. She also has absent bowel sounds. So you can't, when you listen with the stethoscope to her bowels, you don't hear any like gurgling, or that's usually like how I would describe the bowel sounds. Is like if you eat something, you can hear your stomach kind of like gurgling, digesting. You don't hear that. Her abdomen is also distended and tympanitic to percussion. So part of the abdominal exam, I tried to find a video of this, and it was really hard on YouTube to like find a good example of what these findings look like in an actual patient. Probably because if they're having this, nobody's like recording. But when you percuss the abdomen to try to hear what it sounds like and how much air is in there, she's very distended, so very bloated, and also tympanitic. So it sounds like a drum. It's like hyper resonant to percussion. So when you have that tympanitic sound, that means that there's a lot of excess air. Does that kind of make sense? Like if you were beating on a drum, it would sound like that. And then the last thing here is that she also has positive for guarding. So as you can maybe imagine, guarding is like if you're feeling a lot of pain, someone's pressing on your belly and it hurts a lot, your muscles are going to tense up, and it's going to make it harder for them to actually feel under the muscles, to feel the organs down there. And that's sometimes like an involuntary thing that people have when they're in a lot of pain and distress. So guarding is usually something that is like a abnormal and bad finding on exam. For her genitourinary exam, she has no palpable ovaries and uterus, which is consistent with her past history of a hysterectomy. She has no cervical tenderness and no blood in the rectal vault. And when this says, I realize this is a typo here, she wouldn't have a cervix because she doesn't have a uterus, but there's usually like a cuff, like an artificial cervix kind of. No tenderness and no blood in the rectal vault. So again, we've kind of eliminated some of those other things on the differential that would have been related to more like a pelvic or gynecologic type of etiology for this pain. And then lastly, for her extremities, she has normal pulses bilaterally. 2+ is like a normal, it's means that they're equal on both sides, and they're not too like soft where you can't feel them, and they're also not like bounding. And then she doesn't have any observable skin changes, rashes, or lesions, and her neuro exam is grossly intact. So I know that that was kind of a lot, but I really want you guys to just focus on the abdominal portion of this, and then also just the general appearance. Those are the 2 kind of most important parts of this physical exam. Okay. And again, if you need to write down the exact vitals for the note, then I'll just come back to this later. Okay. So what are some things that you guys would do from here? We've gotten a history from her. We've also gotten a physical exam. What are some things that you would want to help make a diagnosis? Fast, yes, perfect. EKG, excellent. These are all perfect. Any others? Ultrasound, good option. Abdominal x-ray. These are great ideas, guys. Any labs? Any blood work? CBC, excellent. Blood cultures, very, very good. Yeah, CBC blood cultures are both huge. Good. Yeah, these are all very, very great options that you've all thrown out. Yeah, CMP or a complete metabolic panel. These are all perfect. I'm really impressed with you guys. Yeah, so someone mentioned a FAST scan. That stands for Focused Abdominal Sonography Test, I think. That's done in more of like a trauma setting, but when you have like a very acute presentation where you need to evaluate someone's abdomen, you can do ultrasound to see for any abnormalities like bleeding or perforations and stuff like that. EKG would be an awesome choice to rule out an MI, which we talked about could totally be an option, especially in a 70-something-year-old woman. CBC and blood cultures are definitely a must. Blood cultures are going to be super important later on if we're determining whether she has sepsis or a bacteremia. Urinalysis is another great option. Yeah, so literally everything you guys said would be a great thing to do. So for us, we got a CT and abdominal x-ray first. Her CT showed, okay, I'll kind of go through these one by one. So we'll first start on the CT. I want to orient you guys first to see that this is kind of at the level of the mid abdomen. So we don't see any liver, which is in that upper right quadrant. And so we're kind of at a level below that. And here you can see sort of the anterior or the front of the abdomen. So like this would be around maybe where her belly button is. And then this is the back. So this is the spine, the vertebral body of the spine. I'm not sure exactly what level this would be. And then, yeah, so then the rest of this is all kind of just bowel and abdominal organs. So here you can see something that's called an air fluid level. All of this black stuff here is air. And so there's a lot of air and it's pretty dilated in her bowel. In this part here, you can see a very clear line where it sort of looks like, I'm just holding up my water. I know if you guys are looking at my camera or not, but like this would be the air and then the fluid down below it. That's kind of where you see that level down here. Similarly, you got these little air bubbles in these loops of bowel here. And those can be indicative of an obstruction, possibly. It's not specific for that, but it can be a sign. Turning our attention to the x-ray now, we see these sort of parallel lines that are running through the middle of the abdomen. This up here, this big bubble is called the gastric bubble. So that's where the stomach is. Notice it is also filled with air. And then down here, this is sort of where, this is the pelvis. And so this would be like where the bladder and the rectum and that sort of stuff would come out. So all through this here, this is the GI tract and this is small intestine. This is called a stacked coins sign, where you can kind of see these little lines that are going through perpendicularly to the route of the GI tract. So they kind of look like if you were to have a roll of quarters or something, all the little coins that are separated. And then small bowel tends to stack on top of itself like this. So it's pretty clear that she has a lot of dilation. So these are all very concerning findings for having a small bowel obstruction, because we have this buildup of air that's kind of in the stomach and in her intestine. We see the stacked and dilated loops of small bowel that are kind of congregating in the middle. And yeah, that's like the main things that I want you guys to focus on here. If you don't fully understand reading images, me neither, and I'm a third-year med student, so don't worry about it, but just know that those are some abnormalities that we're seeing here. Some people had mentioned also a white blood cell count, or sorry, a CBC and blood cultures as well. So we did a CBC and found that her white blood cell count is 24,000. Upper limit of normal is 11, so very significantly elevated here. Her lactate is also at 4.6. I don't think anybody mentioned lactate, and that's kind of a teaching point of this, so I'm actually glad, because then this will be something that hopefully people can take away from this. You don't want to have an elevated lactate. Normal lactate is anything less than 0.5. So typically it doesn't even report as a measured value because it's supposed to be so low. But hers is coming back at 4.6. That's like pretty significantly elevated. And then lastly, we did a gram stain and it showed many significant gram negative rods. So this is likely E. coli, and that's the predominant bacteria of the gut. So this is just kind of, actually, we're going to go back quick. I'm going to go back, but are there any questions right now? And how is this pace for you guys? Is it too fast? Am I explaining things in too much detail? I know in the past I've kind of flown through these, so I've been trying to go a little bit more in depth, at least with, okay, good. Thank you. So yeah, that's good. That's reassuring. I want to make sure we're not speeding ahead. So for the acute abdomen, this patient fits the picture of an acute abdomen, which is something that needs urgent evaluation and treatment. So this is basically going to be, if you're working in the ER, you're going to call surgery right away. You're going to call the general surgeons to come down and do an exam and evaluate this, because she's displaying signs of peritonitis. And the definition of peritonitis is irritation of the peritoneum. The peritoneum is the lining of the abdominal cavity. So you've got the skin on the outside, the muscles, the fascia, and then the very inner lining of the abdominal cavity is the peritoneum. And when you get inflammation and irritation of the peritoneum, it becomes extremely painful for the patient. That's why they have this diffuse abdominal pain to palpation. And it's very uncomfortable. And even just like knocking the bed with your foot, like if you kick the bed, they'll kind of like scream out in pain because it's so sensitive. So that's indicating that there's some sort of really bad inflammation going on inside of the abdomen. The first step of treating acute abdomen is to stabilize their blood pressure. So if you remember her vitals, her blood pressure was like 89 systolic, I think. Pretty sure that's what it was. Either way, her blood pressure is very low. So she needs to have fluid resuscitation in order to bring her blood pressure back up to a normal level. So that happens first before anything else, fluid resuscitation. You want to get IV access and give some fluids. The second step is going to be a CT scan of the abdomen and pelvis, which we got. Other possible tests that you guys totally nailed was the EKG. We got a chest x-ray, we got the CBC, we got a serum lactate level, which I'm going to explain a little bit more in detail later, but remember hers was elevated, and then 2 sets of blood cultures. Does anybody have a guess why we would take blood cultures twice? And I'll give you a hint, they're from 2 different sites that we draw from. Yeah, I'm seeing, because the bacteria might only come up in one of them. That's basically, yeah, so you guys are on the right track here. You want to get 2 sites because you want to have confirmation in both of the cultures. And it's not because there wouldn't be bacteria in both sites, because your blood circulates very quickly. So if you're growing blood in your, or sorry, if you're growing bacteria in your blood, then it would likely be like in your entire body. The reason we get 2 is because you don't want to have a false positive from contamination, if that makes sense. So we've got a ton of bacteria all over our skin. Literally everywhere in a healthcare setting, the hospital is just covered in bacteria. So you can get contamination of like the vials that they're grown in, all sorts of stuff. So you want to make sure that you don't get like a false positive, and it reduces the chances of that because you have 2 separate ones drawn from different sites. If the cultures have to be before antibiotics, yeah. So that's a great point. Who was that said that on here? Is it Purab? I don't want to say your name wrong. I'm sorry, please correct me. But That's also true. So you can use the blood cultures to help determine your antibiotic specificity. So depending on what your bacteria is, that will affect which antibiotics you give. And we're going to talk about that later in this presentation as well. But that is an absolutely true point that if you give antibiotics before you draw the blood cultures, then you will also have like invalid results because they'll start killing off the bacteria before you actually get a true sample. And it might look falsely negative in that case. So hopefully that's a little bit clearer why we do it twice. But that's not really the main point here. I just want you guys to know fluid resuscitation comes first, and then these are the steps that we do to work up a possible peritonitis. Actually, I take my words back. Consult surgery first, call surgery or page surgery, then fluid resuscitate, and then do the workup. But at the same time, we don't want to just like do all of this and burn time and not start our antibiotics because the patient is like clearly has an infection. They have lactate that's elevated. They have their blood pressure is low. Their heart rate is high. They're using up a ton of oxygen. So we're going to start with as broad spectrum antibiotics as is necessary. And usually that's like super overkill. We will eventually narrow the spectrum once we get those results of their cultures. But we start very broadly because we don't want to miss a potential bacteria that is actually causing this infection and then have it grow out of control because the antibiotics don't work for it. So like I mentioned earlier, E. coli is the #1 bacteria that is like native to the gut. So everybody walks around and has a ton of E. coli just like chilling in our bowels, and that's normal. And we need the E. coli in order to function. But when it spreads outside of that contained environment, it can cause infection. So that's why we have specifically antibiotics that target that class of bacteria, and it's gram-negative in case you guys are curious or didn't know that. It's gram-negative, so we use gram-negative antibiotics. What would be the antibiotic of choice here before a culture? So we would do multiple antibiotics likely. I think from what I understand, you get them in the ER, you get an IV, you fluid resuscitate them, you draw the blood cultures quick, and before you get them back, you load them with broad spectrum antibiotics. So you've taken the blood cultures before they're, quote, contaminated with antibiotics, but you're not delaying treatment. So just no broad spectrum. I don't even know, like, this isn't important, but like ciprofloxacin, for example, that's a, what is it? It's a fluoroquinolone antibiotic. I think it works against like a ton of stuff. So it includes gram-negatives. That could be an example, but don't worry about the specific actual drug. Just know broad spectrum to start with. Okay. We already checked in. I know that was a lot more information. I'm going to try to keep it concise, but we're only 35 minutes, so we're doing good. So now I'm going to talk a little bit about the pathology of a small bowel obstruction. So as I mentioned earlier, our patient had a ton of previous abdominal surgeries. She had like an appendectomy, a cholecystectomy, an abdominal hysterectomy, and I don't remember, maybe she had a hernia repair. I don't know, but she had a ton of abdominal surgeries. And these can all cause scar tissue to form both around where they actually had the surgery and then as well as like in other sites potentially. So this is called adhesions, and adhesions are, I think maybe I have a picture of it later on, but they're essentially like bands of tissue, of connective tissue that they do exactly what it sounds like. They adhese either bowel to itself or to the peritoneum or to surrounding structures. And it basically just like is this giant spider web is the best way that I can explain it, holding things in place when they're supposed to be able to move more freely than that. So it's like they kind of get caught in the web, and then that can just like slow everything up, and it puts you at risk for things like hernias and things like strictures, things like, I don't know, you can get like a closed loop type obstruction as well. So that's like the number one, I think, risk factor for having a small bowel obstruction is previous abdominal surgeries that result in these adhesions. Other risk factors is the presence of hernias. So a hernia is the protrusion of bowel through the abdominal wall or through, I guess, like in the case of an inguinal hernia, the inguinal canal and inguinal ligament are kind of in the groin area. So you can get herniation of the bowel through that defect. You can also get other areas. Ventral hernia would be like right in the midline of the abdomen. You can herniate through prior surgical sites. So if she had an appendectomy, the scar for the appendix or from where the appendix was taken out, you can get protrusion through that. There's a lot of different places that hernias can be. So just knowing that any hernia is a risk factor for an obstruction because it's kind of poking through that wall. And so you can have both strangulation of the sort of neck. So in this picture here, I think it does a good job of showing the different layers of the abdominal wall and how you have this bowel kind of poking through and how it can really easily strangulate around the neck, if that makes sense. Another risk factor that people kind of forget about is a tumor or a neoplasm. So things like colon cancer definitely could also compress the bowel and cause an obstruction as well. It's more of a slow process. It's not as acute, but if you have it, like I've seen people with tumors that just like completely crush the bowel and then nothing can pass through. So why did our patient get so sick? How did she go from 6 days ago? She had a bowel movement totally normal, and then she ends up in the ER with this excruciating pain, peritonitis, and going to be going to the OR. This happens because when you have an obstruction, I don't know, think of it as like a clogged pipe, maybe. You get buildup of all that stuff behind it. Like the water doesn't stop running. You're gonna keep eating, you're gonna keep pushing contents through the bowel. And if it's just going against this wall, it's just gonna build up more and more and more over time. That's why we get the air fluid levels. Remember, there's a ton of bacteria living down there. They're producing a ton of gas. Like that's all the gas that you pass like every day. And it's more than you think. It really is. So you get this buildup of stool and gas that's proximal or like before that site of obstruction. And then everything after it just can't pass. So you just build up all that pressure and eventually it can get so high that the bowel just perforates. It just like bursts open and leaks out all that content because it has to go somewhere. So then you get stool and bacteria and all this nasty stuff just like sitting in your peritoneum, which is supposed to hypothetically be like a sterile space. And that's when you get signs of peritonitis and infection. So did I cover everything on here? And yeah, so then basically once you have that bacteria just kind of floating freely in the abdominal cavity, you've got all this stool. That is just like a seeding ground for spreading the bacteria through your bloodstream, causing septic shock. You have such a high metabolic demand for oxygen because your body has so much inflammation going on that your blood pressure is dropping, you get a fever, your lactate goes up. So that's kind of the disease process that made her so sick. Luckily, if you catch it in time before the perforation happens, then you can prevent this whole like spiraling of like your vitals doing really bad and your blood pressure is just like tanking and your lactate's creeping up. And at that point, you can get super, super sick and end up in the ICU. And it's really, really scary. And people will die from it if you don't treat it in time. So, does that process of how it works make sense to you guys? And I know the confusing part is maybe like how the septic shock happens with that, but it's really just like you have this perforation that leaks out the bacteria and then it just like your whole body just goes into shock. Does that make sense? Okay, cool. And then if there's any more questions or if there's anything that you think of in the future about something from this slide or a past slide, then just please feel free to ask. I'm happy to go back. So for diagnosis of a perforation or a small bowel obstruction, we will do a CT scan. It's the most sensitive for this. Ultrasound is good for like very quick evaluations and it saves radiation, but it doesn't really show what we need to see in terms of like a transition point where the actual obstruction is happening. So it's better to get the CT if it's available. Other supporting things for your diagnosis can be their white count. That can show that there's a sign of infection. Obviously, lactate we talked about, that's going to be more of an indication for the severity of your infection, if you are actually septic or not. And then blood cultures as well, so that you can see if the infection has spread to the bloodstream. We kind of already talked about most of these. And I just put an article here. It's kind of old. It's from like 2004. But it's basically just, oops, sorry. It's basically just showing that lactate can be used as like a prognostic measure in critical care situations and in surgical practice as well. Okay. Sorry, I lost my chat for a second, so I was trying to get it back. Okay, we just kind of went through this diagnosis and evaluation before, and I'm putting here now what the definitive treatment is. So really, surgery is the only fix for a perfed bowel. You can't fix it once it's already blown up. And most cases, you also can't fix an obstruction on its own. Like you just have to surgically go and open them up and explore the bowel and either physically like unkink it if it's like a closed loop, if it's depending on like what's causing it, if it's adhesions, then you can go and like cut all of the adhesions, basically just like wiping out all those spider webs and creating a more clear tract for the GI, for the bowel to go through. It kind of depends on what those causes are that we talked about earlier, but surgery is the only way. And to not delay surgery in favor of waiting for your workup to come back. So in some cases, like if they're actively peritonitic and you suspect obstruction, you can just like take them to the OR if you're in a certain environment where you can't get these supportive diagnostic results back in time. It's better to just take them and explore and see if there's anything that you can do, because the longer you wait, the more bacteria, the more infection you get, the worse their outcome is going to be. Again, fluid resuscitation is perhaps the other most important thing that you have to do here, because if they don't have a blood pressure, they don't have anything. So we use things like normal saline or lactated ringers. Those are just like fluids with like some small amount of salt and electrolytes that help. We don't give water to the bloodstream, because if you remember from, I'm sure most of you guys have had like bio or chemistry where, well, I'll see if anyone can explain. Does anyone know why we don't give water? If I'd be really impressed if somebody can explain. Why do we give something with like salt in it when we are giving somebody IV fluids? Yes, multiple people just answered perfectly. It's because water is a hypotonic solution relative to the cells. So it's going to cause all of that water that we give to just go inside the cells and they'll burst open. You'll have like all of this cell death. So, and we don't want that. So we give what's called like normal saline. It's an isotonic solution relative to the like bloodstream. So excellent. Yeah, that's really cool. Helps hemodynamic, I'm sorry, guys, hemodynamic stability. So their blood pressure will both go up and their heart rate should also go down. And then of course, broad spectrum antibiotics to help control the infection. Like I said, you can always go back and narrow your spectrum once you know exactly what you're dealing with, but it's better to start broad rather than start too narrow and then you haven't caught the bug. So for our assessment and plan, here's kind of a picture of the adhesions that I was talking about. And this is just one adhesion, but you can really get like everywhere in the abdomen with adhesions. So it can get really like matted and just like crazy looking in there. But this is a great picture. I think it shows where the adhesion is. It's kind of this like piece of connective tissue that's connecting these two pieces of bowel that's not supposed to be there. And then just happens to be strangulating this other more distal part of the bowel here. And you see just how dilated it looks. It can really be this dilated, like relative to this is normal small bowel in here. Normal small bowel is less than 3 centimeters, which is about a little over an inch. So that's like that's not very big. It's pretty small actually. I was a little surprised when I first saw it in surgery. And you can get some extremely dilated small bowel when it's obstructed. So that's a really good picture of an adhesion. Back to our patient, we took her to the OR for an exploratory laparotomy. This is a very common emergency surgery that's done if you don't know exactly what you're dealing with. So you just make a big incision down the midline of the abdomen and open the peritoneum, and then you just, what we say, run the bowel. And that's starting from the top of the stomach where the duodenum connects with the stomach. And you feel and just like check and visualize all of the bowel going all the way down to the ileocolic junction. And that's the entire small bowel. We found in this patient multiple adhesions and a transition point, like I mentioned. Sometimes you can see it on CT and sometimes you can't. This picture does a good job of kind of depicting what a transition point looks like. It's exactly what it sounds like. It's where it transitions from being like normal to like super dilated. In this patient, she had a perforation as well. So we performed a resection, and that's, I don't know if you guys can like see my cursor here, but you basically just cut physically with some surgical instruments, both like proximal and distal to, or before and after, sorry, I keep using anatomic terms, and I don't know if you guys are familiar with those, to the actual transition point and where the perforation was. And then you will religate the pieces of bowel back to each other to establish continuity. That's called anastomosis. It's where you connect two things together. And then this patient, because she was so sick, she had this awfully high lactate. She was admitted to the hospital for continuation of her treatment. We gave her IV antibiotics, IV fluids. Eventually, you have return of bowel function, and she made a full recovery. I write these cases, they're not real, and I always give them happy endings. So sometimes it's not always like that. I think one of my patients from a couple of weeks ago is still in the ICU for having a very similar presentation to this. So what time is it now? It's 8:50. So we're still got 10 minutes technically before the end of this. If you guys have your SOAP note and want to go back to any of the slides to fill out the subjective or the objective parts, I'd be happy to go back to those. If not, please let me know if you have questions about small bowel obstruction, general surgery, or medical school in general. I would be so happy. Quiz link, yes. I'm so sorry. I don't know why it's like still not showing up for some people. I'm putting the link in here again. It's just this Google form. And the quiz is at the bottom. So the SOAP note is the first part, and then the quiz will happen in like the middle or maybe towards the end. And then the last part is a feedback. And I really do listen to your guys' feedback. I think someone had requested a surgical topic last time, and not just because I'm really interested in going into surgery, but I do want to hopefully provide some information that you're actually interested in, because I love doing these. It's both good for me to learn and to also hopefully give you guys some more exposure before starting med school, because I never had anything like this, and it'll really prepare you to know kind of what the terminology and everything is. So what questions do you guys have? We can sit here for another 10 plus minutes. I don't have anything else going on. I'll probably wait until people are just like leaving the meeting. And that's usually my cue that we're done. but can I explain more in depth about the high lactate level biochemically? Yes, that's an excellent question. So the way that I think about it is, have you guys learned about like glycolysis and like lactic acid buildup, or like using lactate dehydrogenase to like in low oxygen conditions at all? I know it's kind of like a biochemistry thing. And so if people are earlier on in undergrad and haven't had that, then they might not know. But basically, so during normal cellular respiration, you use oxygen to be the electron acceptor. Also, this is really sending me back. I haven't done this in like a couple of years, so bear with me if I'm not technically correct on this. The electron acceptor at the end of cellular respiration. And so that's like normally what your body does. In low oxygen situations, you can bypass the citric acid cycle and the electron transport chain and just go through glycolysis with the process of using lactate dehydrogenase to kind of just go through that process more in order to like create the ATP. And that can be done without using oxygen. So in lactate, I think of it like this. If you have all of this infection and inflammation going on in your body, you're producing a ton of white blood cells that are metabolically using a lot of that oxygen because they're fighting the bacteria. That's your only way to really keep that at bay. So with the low oxygen state, because they're using so much of it, and you're also like leaking a ton of fluid out, your so these cells are in your blood, they're circulating and they're recruited to certain parts of your body where there's infection. So they will extravasate from the vasculature and all of that fluid will go with them. That's why you get swelling. And then that's what also brings down your blood pressure, probably because these patients are sick, they're vomiting, they're not taking in fluids. They are also losing a lot of fluid by having their white blood cells leak out of their vasculature. So their blood pressure is dropping. They're using up all this oxygen and they're shunting, basically like going through this lactate metabolism versus because you don't have enough oxygen to support normal respiration. That's kind of the idea behind a elevated lactate level. It's because of the immune system using up all that oxygen, trying to fight the infection. And that's a super interesting topic. Like, I don't even know if I fully understand it yet. So if you're interested, I would encourage maybe just to do some reading if you're interested on it. Or I can also see if maybe there's anybody who's planning on doing a talk for like critical care or septic shock, things like that. We can have like a whole session dedicated to it as well, because I think it's really important in medicine and it's definitely something that people don't really learn about until later in their training. So there was a question, will these patients benefit from pressors as well as with other septic cases or only fluids? That's a great question. So typically what we do is we first line will fluid resuscitate them. And that sometimes is enough, sometimes it's not. So you kind of progress through the algorithm, I guess. And if they're still low, even after giving them like liters and liters of fluids, then you kind of are forced into giving them pressors. The way that pressors work, there's a couple different mechanisms. One is through vasoconstriction, so it can constrict the blood supply to the bowel. I don't think that's really the priority in this case because you're going to be cutting it out anyways. So like the necrotic part of the bowel, like if it vasoconstricts even more than that, then it doesn't really matter. But in certain cases, like vascular patients, if they have like peripheral arterial disease, we've had some really unfortunate cases of patients who already have bad blood supply to like their extremities. And if they have to be on pressors, then like they can literally lose limbs because they're constricted so much. So it's kind of a case by case basis, like and there's multiple different mechanisms. So there's ones that are vasoconstrictors that'll kind of bring the blood from the periphery back into the central part of like your high demand organs, like your heart and your brain. Other ones can work by increasing cardiac output. And yeah, so there's a couple different mechanisms that you can use. Hopefully that's helpful. It's a great question. Pressors are definitely like a case by case scenario and only used in like very critical, unresponsive, or refractory cases.